Now talking about children with special health care needs. And while you're out there doing your clinicals, if you haven't run into it yet, there's actually several places here. We used to have a pediatric nursing home that got shut down for bad stuff. No, this was bad stuff. They had some adults in the back too, but stand by. Will somebody remind me at break to reset this computer? All right, let's try this again. So, we used to have a pediatric nursing home here. Most of those kids were kind of wards of the state, so we got to be pretty good at dealing with special health care needs. So, but as a result, when they closed, where did all these kids have to go? Well, there's some homes, even here in town, that they actually are foster parents to special health care needs children. So they have a large house and they have lots and lots of kids that are on home ventilators and trachs and stuff like that. So you definitely need to be aware and you need to know kind of a little bit about these special health care needs.
Why can't you wear watches or making babies?
I don't know.
They're like, you don't touch the baby that you watch on.
Probably because they're worried about it either being too cold or scraping or scratching because their skin's real thin and stuff. That'd be the only thing that I could think of. I have no idea otherwise. Probably. All right, so some different types of kids. So there's premature infants, and they're going to have typically pulmonary disease because we know that the lungs are the last thing to kind of finish developing, and that surfactant doesn't come into play until later on. So if they know they're going to deliver a premature baby, they may get surfactant injections, hoping to kind of increase it a little bit. And then kids with cardiac disease. And then neurologic deficits also, or congenital defects. Okay, congenital defects can fall into this cardiac stuff as well. These children more and more often are living at home. Okay, parents may have nurses or respiratory therapists that come and assist them or aid them, or they may take care of it predominantly on their own a lot of the times too. And some of them are really dependent on technology. Okay, so tracheostomy tubes. Tracheostomy is basically kind of like bypassing all of this. Okay, if you kind of feel here on this little spot on your neck, you kind of feel how it kind of goes down. Feel that little V? They essentially go right into the airway there. It's a surgical airway, and some of them remain permanent. Okay, so there's some different types of tracheostomy tubes, kind of like this. Okay, so some of the complications that you're going to run into is obstruction. These kids generally tend to have a lot of mucus, so they can get mucus plug. It's not uncommon for them to squirt some saline straight down that tube so that it can loosen up the mucus and the secretions. Because again, remember, to take slime, add water, you create less thick slime, okay, or thinner slime. And then they can have bleeding around the site or an air leak. So if they have this kind that's got this little inflatable cuff on the end, okay, and they will have, you see this right here? That's just like on the king, and it's going to kind of indicate to you how full that bulb is at the bottom, okay? And it can become dislodged or get an infection, okay? The thing you need to know, depending on the age of the kid, how old the kid is around, okay, the parents have probably tried a lot of this stuff before they call you, okay? There are parents that can change out their kid's tracheostomy tube. You just kind of slip it out and slip the other one in. Okay? So what are you going to do for them? You're going to maintain the open airway, suction them as needed, position of comfort, and then transport. Now to suction them, kind of, you see how it goes straight into the airway? It's a much smaller, okay, depth. And you may have to ask them because they can probably tell you how long the trach is. You don't want to go past the trach. You see this? Okay? You're going to stay kind of in that limit. Home ventilators. There are lots of different types of home ventilators. Look at that kid. He's a champ. And then parents typically are very, very knowledgeable. And again, they may have staff on hand, either respiratory therapy or nurses who deal with this all the time. Okay? So some of the things that may be a complication is it could be dislodged or an obstruction. Again, you're going to see a lot of the same things. Pneumothorax, not just if they've just recently adjusted the vent settings, but that's one of the things I want to know is how frequent do we do it. And then you can also have like equipment failure, either by power failure at the house, which most of them have a battery backup, or equipment failure just all around. Unfortunately, sometimes vents do fail. It doesn't happen very often. Okay? What are you going to do for them? Assure the open airway, ventilate, and oxygenate, transport as needed. So if you can't determine if this is a ventilation, so is it a ventilator problem, or is this like a mucus plug or some dislodgement type problem, if you have a question, unhook the ventilator and bag them. The ventilator is essentially a bag in a box, right? It just makes sure it's very controlled. It knows exactly how much volume they get and exactly how much time they deliver it and how long it takes to do that, okay? They are just being bagged all the time by a machine, okay? Huh? The great thing about EMS and medical supplies in general is no matter what brand, what style, or anything that you use, they are all the same size, so they're all compatible. So your BVM will hook to all tracheostomies. So even that the trach tubes may be very, very small, the end coming out is still going to be the same size. Just like your masks will fit, any mask will fit on any BVM that you have. It's a universal fitting. Okay? Central lines. So basically, this is an IV, and this can be a few different things, okay? So they usually are in the thorax, so you'll see them a lot at the subclavian area, okay? Kind of right around here, and they go into that artery. They feed into the artery and go directly kind of right at the opening of the heart most of the time. You also have a PICC line. That's a peripherally inserted central catheter. So PICC lines are very, very long, and they typically go here at the AC or the brachial artery, and they're actually arterial lines. They go in and they feed it all the way in to right at the beginning of the atrium. Okay? And they do that for these kids that are very hard to stick or they have to get stuck a lot. All right? So some of the complications, they can get a cracked line. Infection. Infection is a big deal. Why is infection a big deal? Yeah, it goes right to the heart, and it actually causes staph in the heart on the valves. Okay? That's bad. Okay? You're right. It's a direct line. They can actually be clotted off, and there may be some bleeding near the site. Well, why is that problematic?
Well, that can cause infection too, can it?
Because it's an artery.
Because it's that's exactly because it's an arterial line. They're under pressure. They bleed a lot. Okay? So you got to be careful of that. So here's one. And look, sometimes they're little buttons. And I mean that literally. You'll have to feel. So how many of you guys have ever felt the medication lid kind of as you pop it off? Do you know what I'm talking about? Are you with me, Cody? On the little vials of even like saline or anything, we used to have these little pop-off tops, and then they punctured the needle with the top. Okay? It'll feel kind of like that underneath their skin. Matter of fact, I bet yours feels kind of like that, doesn't it? Where your pump goes in. Okay? And so they can be kind of in different forms. It may not necessarily be a tube hanging out. Sometimes it's like two lumen, and they'll have a red and a blue tip. Okay? And that just tells them kind of, yep, which is which. Okay? So what are we going to do for them? Apply sterile dressing, apply pressure if they're bleeding, and transport. Kind of depends on why they have it and what's going on. So do they have a raging infection that they put a PICC line in so they can give antibiotics? It really depends. So a lot of kids will outgrow them and they'll take them out, and once the incidence is done, they're done. When you're talking about special health care needs, these are kids who typically have them long term. And I hate to say long term, lifelong, because these are inserted also because they are long term. So when you guys are out there on the trucks and they start lines, or even in the ER, when they start a line, those are only good for about 48 hours, 48 to 72 hours. Then ideally they need to be switched. They need to be changed out, those peripheral lines, so they don't have the durability that these lines have. Gastrostomy tubes or gastric feeding tubes. Okay, this is a tube that's basically put directly into the intestine for feeding. Okay, these are for babies that have like a lot of reflux, or if they continue to reflux and they get pneumonias then because of aspiration type stuff, okay? There's lots and lots of shapes and sizes. They can be dislodged. They can get infections or bleeding around the tube. Respiratory problems. So for those, you're going to maintain the airway and suction. You got to watch for hypoglycemia and dehydration, okay? Because it depends. So some of them are on a scheduled feed and some of them are continuous feeds. Just depends. Kind of the best way to describe this is you see this kiddo's got like a tube that comes out. They can actually have bowel contents. It looks like bile is what it looks like. And if it gets around that as it kind of leaks a little bit, it can cause like a burn because it's kind of acidic. So it can cause a burn kind of around the site. So they can have some local reaction too. So you see this picture, and it's that kind of like that. It looks like IV tubing, but it's thicker that comes out. A lot of times what you'll see, how many of you guys have blown up an air mattress or an inner tube? They look exactly like that little plug that lifts up and pokes down in. There'll be just a button right here, and you just lift it up and plug it in.
We came across a really crazy one when I was in the ER. The nurse had been there for like 12 years, and she'd never seen the kind that this kid had.
Really?
Yeah, and they had to call in somebody special to find like the right equipment because his was so unique. So they even got a line trying to look it up, and it was something that, because he knew what it was.
Just didn't have the stuff for
Yeah,
it?
they didn't have the right piece. And they said that was really weird because typically all of them are, you can use the same thing.
Yep. Again, so ensure that they have an adequate airway. And this could be, again, did they aspirate? You know, what exactly is going on here? So suction is needed. Use a sterile dressing. See that? That's kind of what I was talking about here. Use a sterile dressing. Apply pressure if it's bleeding. And then transport. They need to be in a sitting position because if you lay them down, they're going to aspirate. Think about this. Remember this with your elderly patients. They can't lay down for, I think it's an hour, maybe 2 hours after they've completed a feed. So that doesn't mean you lay the bed flat just long enough to slide them over to your stretcher because that's all it could take for an aspiration to occur. Lift the head of your bed up. You can do that. The patient doesn't have to be flat all the time. Okay? And then, or lying on the right side with the head elevated. Okay? Shunts. Shunts are these devices, okay? And there's a couple different reasons. So basically, excessive fluid on the brain, whether it's cerebral spinal fluid, typically that's what it is, okay, for encephalitis or whatever, or CP, various different things will kind of have encephalopathy, which is fluid on or water on the brain. So here's how it works. There's a little tube that literally goes kind of into the ventricle of the brain, and it tracks, and they all track behind the ear. You can feel the button. You can feel this tube. And it goes into one of two places. It'll either go into the right at the main right atrium so that it kind of dumps it back into the central circulation, or it can go right into the GI tract, into the stomach, to dump it so that your body eliminates it. Okay? Nope. 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 Mm-mm. Nope, not at all. Obstructions. They're going to, unless this is their first time, and they've been well educated typically, even if it is their first time. So when they know they've got a shunt malfunction, which is usually like a clog, these guys will start with things like headache, vomiting. Those are the two big indicators very early on that they have a shunt malfunction and it's not working. So they're going to start developing that increased intracranial pressure. Okay? Seizures, changes in mental status typically happen a little bit later. So you want to kind of find out if they've been complaining of a headache, have they been vomiting, any of the sorts. All right? These guys are prone to respiratory arrest, so manage the airway, oxygenate, ventilate. They need to be transported. Okay? So here's the two different types. So you see that it kind of comes here. Behind the ear, there's the little button. Right down here into the stomach. Or here, there's the button, and right into the heart. Okay?
So that little boy or whatever has encephalitis?
Yeah. Well, I don't know what condition he's got, but whatever condition he's got, it probably like a tumor, is causing the encephalitis.
Oh, okay.
Okay? Questions? No? Cody, you're dying to ask a question. What are you thinking?